Now, the post-op course, I put them in a post-operative shoe. They are allowed to full weight bear. I actually tell them the day after surgery, I actually want them in their house walking around with just the post-operative dressing on. Basically, and I tell them, I want them to pretend they're a ballerina. So if you look at my foot, I even walk out and tell my patients, the day after surgery, I want you going up on your toes and going up and moving. And I explain to them, this is basically a knee replacement for your toe. The idea is you want immediate early range of motion. And so I encourage my patients to walk around in their house without the shoe on, working on bending that toe, getting it moving. I encourage them to wiggle their own toes, to move them, because you want motion. Don't hold them still. Everybody worries about wound problems. But the truth of the matter is, you've made the incision dorsally. So when you work on dorsiflexion, you're not pulling on the wound. So you're not going to have wound problems. And so, whereas with a total knee or knee replacement, you're trying to bend it down, you're going to stress that incision. On this one, you're not stressing the incision. So you force them to move. You don't want them sitting around for a couple weeks because they will get stiff. So by 2 weeks, they're starting physical therapy, they're starting their motion. I encourage them to get into whatever shoe wear they want. I encourage them to do all their activities. And that's really the surgery. The other thing everybody asks me about is, oh my God, are sesamoids going to work? You've just done this release. So what I'll also do is if you'll notice, I do her range of motion. She's got motion. It's wonderful motion. And I'll show you something. So what we're going to do now is I'm going to just be doing this motion up and down, and then we're going to put it under X-ray. So we're going to watch the X-ray machine now. So as we dorsiflex, Junior, go live fluoro, you can look at those sesamoids, and you can see that as I dorsiflex, those sesamoids are moving, and they move along with the joint. And so people ask me about, well, because of all your releases, the sesamoids aren't going to move. They do move. And that comes back because there is the FHL right in this area. And so you can see, go ahead one more time. You can see that the sesamoids move up and down on the implant as we dorsiflex and plantarflex. So it's a nice lady. She has hallux rigidus. She's had it for a long time. She's obviously failed all conservative treatments. You can see from the x-rays that most people would probably call this maybe stage 2, maybe an early stage 3, but most likely stage 2. She has some well-preserved lateral joint space, but the medial joint space is pretty narrow. Classic subchondral sclerosis, some spurring, changing in the shape of the metatarsal head. And there's the oblique view. You can see very, very similar. So what I'm going to do is change this real quick to the lateral view. Again, you can see the lateral view. Lateral view. You can see the classic spurring, some spurring on the phalangeal side dorsally. The interesting thing is X-ray will always underestimate the extent of the disease. And as we do this patient today, you're going to see that most likely she's going to have eburnated bone all the way to the plantar surface, because this would suggest that you could probably get away with just a simple cheilectomy. But I bet you when we get in there, we're going to see that she has eburnated bone all the way to the plantar surface. So I always, whenever I say I'm going to do a cheilectomy, I also talk to them about an arthroplasty. And the reason I do the arthroplasty, or I have them consent it, and I tell my patients, it doesn't matter which operation I do, your post-op recovery is going to be the same. I make you get up and walk on it either way, no matter what I do. And so patients are very okay with that because they understand my post-op recovery is the same, and he's just going to do the right thing to get rid of my arthritis. And this actually, x-rays always underestimate the extent of the disease, so I'm always prepared to have a joint replacement when I do my cheilectomy so that I don't get surprised. So you'll notice that once we've done this procedure, preoperatively you can see there's an angulation to the, there's an angulation almost in a slight varus because of the erosion on the medial side. And you can see the spurring on the dorsal side here. Postoperatively, and I'll just put these right up over top, or at least so we can compare them. So when you look at the AP preoperatively to postoperatively, you can actually see that we've restored from her being in a slight varus to actually being in the more natural, just a very mild valgus. And we've been able to recreate her articular surface so it's more natural for her. And so you can see that the posts are well fixed on both sides. This is going to give her all the fixation. And we saw from the video how we were able to realign the joint. And then if we take the lateral film, again, you can see it, and it's probably not as well on the lateral surface, but what you can see is that we've gotten rid of the spur, and the implant actually takes care of that part. But on the lateral, you can also see the posts are sitting right into the metatarsal. This is actually the metatarsal. The post is sitting nicely in there. The phalangeal side, the implant sitting nicely in there. And even on the lateral, they're nicely aligned. Sesamoid sitting under the metatarsal head. And the only other thing we didn't do is, in this case, we didn't have to, but we didn't alter the relationship between the first and the second metatarsals. You'll notice that the first metatarsal is just slightly, maybe a millimeter or two shorter than the second. And if you actually look at the end of the metatarsal head, it is still in pretty good alignment within a millimeter or two of the thing. Again, all I'm really doing is recreating the surface she had before she developed arthritis.